Good afternoon, everyone. Now we are heading to the second session of the workshop, that is Principles of Motivational Interviewing, an interactive session and insightful talk, presented by Dr. Udit Panda, MD, DMD, Postdoctoral Fellow, Addiction Medicine Enhance, Bangalore, Assistant Professor Gims. We will have online expert Dr. Dheeraj Katola, MD, DM, Associate Professor, CMC Vellore. Subject expert Dr. Surjit Sahu, Professor, Some Hospital and Medical College, Bhubaneswar. And as moderator, we have Dr. Sarmishta Priyadarshini Ma'am, MD, MKCG, Parampur. I would like the subject expert, Dr. Surjit Sahu, to please come on stage and introduce us to the theme.
Hello. So, Udit did not need any introduction because he is having a tremendous job experience with de-addiction, and he had done the de-addiction period. After that, he has joined the team, and he is also product of SPVT college. Then the important thing is I'll just tell you one story, very important thing. Many times people refer to this patient to the psychiatrist like this, at the end of this, when the patient is, there is the liver transplant is there, or when the patient will go to graveyard. So this like situation, they will tell you that थोड़ा counseling कर दीजिए तो छोड़ देगा alcohol. Like this, they will tell that just go for a counseling and heal. So sometimes it is a very embarrassing situation. Then you will think that you will counsel to the patient's family people or to the patient or to the doctor. So this becomes our inadequacy of knowledge that when to refer this patient and when the patient will get the benefit. That is the most important. Everything, because he will be recently the patient was admitted at least 6 times in one of the departments, and they have not referred to this department, referred to the psychiatry department for de-addiction planning and other things. But when we ask the same question, why did not you come? I asked each patient, why did not you come? Then the patient was telling that the doctor did not ask me, and if the question asked to this concerned physician, then we replied that the patient is not motivated. Patient is not motivated to go, and family members are not also willing. So this is the part of the stigma and motivation and other things like that. But I thought that it is the part of this physician. They should be very much properly taught about what, how to motivate. But they are motivating this patient for hospitalization, and they are earning money from this patient. And patient is arthritis and liver transplantation is waiting. So these are the things. So in de-addiction, after detoxification, people think that the job is over and he will not again take this alcohol. But the thing is that the craving is the most important part. When the craving overpowers, the motivation is most important. So our planning of motivation, whether it is MET therapy or motivational interviewing, these are all very important parts to the patient to be not to brought back to the addiction process again. So this is an important topic will be discussed, and this topic is divided into 3 parts. First, Udit will show you a video, then Udit will give you some insight to that, then what to do, what not to do, what to be asked and what not to be asked. Then Udit will tell that what is to be asked and how to do this motivational interview. So let us start the topic, and anybody is there? Or Dr. Dheeraj to actually tell something. You can unmute that. So Dr. Dheeraj, please unmute and start telling about from a long distance.
So thank you, sir, for giving opportunity to be part of the session. Thank you for the introduction. You have actually brought out the importance of the barrier to even reaching psychiatry. But if we see people who do reach psychiatry, there are challenges even if the person comes himself seeking help, telling, I want to get, I have a problem, please help me. Addiction being a chronic relapsing disease, even treating any person who's motivated itself is very challenging. However, we have this group of patients who are brought by the families because there's a health problem going on. Doctor has referred because there's a health complication. Family has brought him because he's creating some trouble at home. There is conflict with society, law, etc., because of which he has been brought. But patient doesn't see a need for any change. So the challenge for the psychiatrist would be to how to bring about change in him when he himself is not interested. So motivational enhancement therapy or motivational interviewing is all about how to rather than this educative model, मैं बोलता हूँ, see, I am your well-wisher, I will tell you, you listen. Rather than that, how to engage with them and move in the direction in which they towards the goals that they have, with our focus being on substances and how to towards the goals that are set by them in a collaborative manner, be it to reduce to a level that is not harmful or towards abstinence, which many times we aspire for. I think I would end with this, and I would request the organizers to show the video before Dr. Udit takes over.
Okay. Thank you for the generous introduction for me as well as for the topic. Dr. Dheeraj, nice to see you. Thank you for joining. Hi, good afternoon. My name is Dr. Udit Panda. I am an assistant professor in psychiatry. I have joined KIMS a few months back. Now, I have two jobs at hand today. I'll be speaking about the principles, or mostly I'll be outlining the principles of motivational interviewing, what it is, how do we do a motivational interviewing, and what do we expect at the end of the sessions of MI. But more than that, I think I have a more difficult job at hand right now, is to capture and sustain your attention after the tasty lunch that we had. So to kind of bring your focus a little sharper to the topic, I'll start out by showing you a video. So let's, I request all of you to assume the role of movie critic. So this is a video where I, myself, and one of my good friend, Dr. Daniel, we have acted out a conversation between a patient and a doctor. The patient has come, patient in the sense the caregiver has come with an ear infection of a child. The doctor incidentally finds out that the father is a smoker, and they're having a conversation about his smoking behavior and how to quit. I'll not divulge any more material to the video. I request all of you to pay attention, and we'll act out the same scenario with a different script at the end of the presentation, and we'll probably have a discussion on that. So give me a moment to share the video screen.
Role play demonstration. I am Dr. Udit Panda. I am a consultant psychiatrist working at Nimans Digital Academy. I'll be playing the doctor's role in this role play. With me, we have Dr. Daniel. Daniel, can you please introduce yourself?
Hello all, I am myself Dr. Daniel. I am currently working as senior resident in Nimans Digital Academy.
Thank you, Daniel. So Daniel has agreed to play the role of the patient in this role play. Now, the case scenario is that a 40-year-old man who is currently employed in a private setup has come to his family physician with his son. He wants to get him evaluated for repeated ear infections. Now, the doctor has found out that the father is a smoker. They had filled out some questionnaire, and there the doctor found out the father is a smoker. The following is the conversation where the doctor is trying to advise the father to quit smoking. I'll begin. Hi. So I wrote a prescription for an antibiotic for your son. That will help with the ear infection. But it seems like he has had 6 or 7 of these infections in just the past 1 year. That's really a big problem.
Yeah, it's pretty stressful for both of us, doctor, and it's really upsetting for us.
Well, one of the primary risk factors for multiple ear infections in kids is usually smoke exposure. Are you smoking at home?
Yeah, I do smoking, but I don't smoke around him. I try really hard not to smoke around him, doctor.
Oh, the fact that he's having these ear infections, no, it's indicating to me that he is being exposed to smoke. What can you tell me about that?
Oh, I don't know. I mean, I really try hard not to smoke around him, and I don't smoke in the car around him. And when he's in home, I go outside to smoke. I know it's bad, and I know it's bad for him, so I don't want him to be around. I really try hard, doctor, not to smoke in front of him.
See, I really need you to quit smoking, both for your health and your son's health. Did you know that smoking around your child is associated with not only ear infections, but it would get to a point where you have to put tubes in his ear pretty shortly. There are also things like vitamin C deficiency, dental cavities, behavioral problems, asthma, so many other respiratory infections. It's putting him in a lot of risk. In addition to kids of smokers end up smoking themselves. You want him to be a smoker when he grows up like you? No.
I have thought about quitting, doctor, but it's just really hard for me. I just don't know how to go about it.
Okay, well, now it's time to quit. It has really gotten to the point where you can't really keep smoking. Not only for him, like I said, but also for you. You are putting yourself at risk for lung cancer, for emphysema, oral cancers, heart disease, all kinds of diseases.
Oh, I know. I have had people have told me before. I have had all that. I just don't know how to do it. Now, how I am supposed to quit? It's so hard for me, doctor.
What hard? There are all kinds of things you can use now. It's not as hard as it used to be in the past. You know, you can use nicotine replacement therapies like patch, lozenges, gum. There is a nicotine spray available right now in Amazon. You can take various medicines like Champix or Bupron. You can try counseling. There are so many quit lines, so many helplines, so many counselors available to talk to. There is absolutely no reason why you should not be able to quit. This is really important that you understand this.
Oh, I know it is. I mean, everybody has problems, right? For me, it's just really hard.
Well, what can be more important to you than health of your child? I don't really understand. I don't know how I'm going to convince you, but you really need to tell me right now that you are going to quit smoking. This is very, very important.
Okay, I'll go and look at all those things, and I guess I try to find something. I'll talk to a counselor about it. Is that okay?
I think you really need to think about it seriously, but this time it has gone too far. Like I said, it's really putting yourself and your child in danger. I'm very serious.
Okay, doctor, whatever. I'll see what I can do for that. Thank you.
Okay. Apart from my Oscar-worthy acting in that video, how do you think I did as a doctor? Can I have some audience response? Yeah, so people are saying for the online audience, you can also respond through chat. People here are saying that I did very bad. Can someone say what bad I did? I had all the good intentions in my heart. I wanted the father to quit smoking. I wanted the son to get a better environment. So what bad did I do? I made him frantic. I was on his face. Isn't that? I was trying to put him in a guilt trap. Yeah, and basically to sum up, I basically activated my writing reflex. You know what is a writing reflex? It's probably there inside every one of us. Every doctor, therapist that you see, good or bad, you all have writing reflex. It's the reflex or it's the intuition inside us. When you see something wrong happening, you have the inherent tendency to correct it instantaneously. Oh, you are wearing a dress that is a little longer. I'll point it out. So it's something like that. That is what we do with people who use substances and they are not really eager to quit right now. Okay. MIE is an approach, or motivational interviewing is an approach that just talks just the opposite of it, just the opposite of writing reflex. So that is something that I'm going to talk about today in the next 15 minutes. Then I'll probably show you another video where I've acted in the same intensity, but with a different theme. Okay, so today I'll be discussing about the concept of motivation, the concept of ambivalence, and the concept of change talk. Then I'll move on to outline the spirit behind motivation interviewing. Then I'll talk about the principles of motivation interviewing. And I'll outline few techniques on how to elicit change talk inside a client through the purview of MI, through the purview of motivation interviewing. So what is motivation? How do we define that? It's nothing but a way to talk to people about change. It's a method of talking to people about change, about things which they have very mixed feelings about. So be it substance use, be it losing few pounds or few kgs of your weight, leaving non-veg food, buying a car, changing your job place, anything that people find it a little uncertain about. Talking about that is the technique to talk about that is something that constitutes motivation interviewing. And this is not a way, I repeat, this is not a way of manipulating people into doing things that they really don't want to do. So it's not something that I'm going to talk about today. If you have come with the hopes that Dr. Udit is going to teach us how to switch minds of people by giving a magic therapy or magic pill, when they come to your clinic, they say that I want to drink alcohol, and they go out saying I do not want to drink alcohol. That is something that is not going to happen. Okay. Okay, so before we delve into the topic proper, let's talk a little philosophy. So there are three ways with which you can see people's illnesses or people's problem. The first one is the deficit model, where let's talk about addiction because I'm an addiction psychiatrist, so I'll talk about that. So in deficit model, the therapist thinks that people are fundamentally flawed. So addicts, let's call them, because that's the term we normally prefer not to use. Let's call them addicts for now. So addicts are fundamentally flawed. They have a deficit inside them. And it's the job of the therapist as a director of the life to give them what they want or give them what they need so that their life changes for the better. The exact opposite of that is the humanistic theory, which is propagated by Carl Rogers and all. They say, do not act as a dictator or act as a director of the patient's life, act as a guide, because they believe that addicts have an inherent tendency and a potential to grow in a positive direction. It's the job of the therapist to elicit that tendency, to elicit and expose that potential so that they move towards change, they move towards being a better self. So this MI, the core of MI is basically based on this humanistic theory. The therapist in MI acts as a guide rather than as a director. Okay. Another theory I want to discuss before I start talking about MI is the motivation to change. Now, motivation is a dynamic concept. You want to buy a new mobile phone, so you might contemplate regarding that for some time, for some months, maybe years before deciding to buy. When you are not considering a change in a behavior, the stage is known as pre-contemplation. If you have a dual mind, so you have both for and against factors to bring that behavior change, let's say quit alcohol, let's take that common example. So you are said to be in a phase of contemplation. Preparation is when you are still using alcohol, but you actually plan to do something about it. So you have a plan at hand. Action is when you stop drinking and take some positive behavioral changes, put it into practice. Maintenance is when you have stopped for some period of time. And finally, you can continue on maintenance or you can fall back to using again. Let's say that you have relapsed. And this whole cycle of pre-contemplation, contemplation, preparation, action, and maintenance was given as a stage of change or a cycle of change by two scientists, Prochaska and Clemente. MI or MI when applied as a therapy is known as MET, motivation enhancement therapy, is meant for people who are either in a pre-contemplation or in a contemplation phase of motivation. So either they are not considering change at all, or they are in an ambivalent phase. They are in a dual-minded phase on whether to attempt that change or not. So these are the MI guys. These are the two guys who have given the concept of motivation therapy. Dr. William Miller is a psychologist who works at the University of New Mexico, Albuquerque. He was working with people who have problematic drinking. Initially, he was like us only. He was shaming people. He was trying to confront them. He was trying to be on their face like I was being in the video. That did not work out. That headbutting with the patient did not work. So he decided to drop any of the suggestions that he has and just listen to the patients about it. Then in one such conference like this one, he met Dr. Stephen Rolnick. Dr. Rolnick was also doing the same thing, but in a different place in Glasgow. So they talked about it. They said, yeah, I'm also facing the same problem. And I have seen that our belief about substance use and the belief that these people who have problematic substance use, it's completely different, but they know what to do and what to not do. But they have the reasons to continue. That's why they're continuing. When the reasons not to continue becomes more, they decide to stop. So that is where this seed of motivation interviewing was born, the concept of motivation interviewing. They further collaborated and basically wrote a book on MI. This, I think in 2013, they have published the 3rd edition of that book. It's available in Amazon. So this Miller and Rolnick, they said, anybody who has a problematic behavior, they will definitely have ambivalence inside their mind. And what ambivalence? At one point, they'd be thinking about some factors to continue that behavior. Let's call that the sustained talk, in the sense sustaining that behavior. So if I'm drinking alcohol, I'd have some things in my mind that will tell me that I should continue drinking because it makes me a hero in the parties. It helps me sing better. It helps me sleep better. It kills my anxiety instantly. It helps me mix with people and talk to people in an easier way. These are sustained talks for drinking or continuing drinking. Then there is another side of that ambivalence. Let's call it as a change talk. When the person is thinking about a change in that behavior. So maybe I can stop drinking every day, it's getting too much. I should stop drinking in the weekdays. I should only drink in the weekend, Saturday and Sunday. I should reduce my drinking to 2 pegs per day. I should drink only on Sundays. Alcohol is ruining my family life. Maybe I should take a break for 6 months. These are change talks. So you understand there is a balance between the sustained talk and the change talk. When the sustained talk side is heavier, people continue to engage in that behavior. Let's say drink. So people continue to drink. If the sustained talk inside their mind is on a higher side, it's heavier. When the change talk becomes more inside their mind, they start considering for a change and they bring in behaviors that facilitates that change. So they say, we'll do this in MI. We'll explore people's ambivalence. We'll talk to them and help them explore their ambivalence. We'll help them resolve their ambivalence and either elicit or increase the change talk. So that's essentially the target of every motivational interviewing session. You help the patient explore their ambivalence. You help them resolve their ambivalence and you increase or elicit or evoke is the word, change talk inside them. Okay, there's some theory that I want to speak to about MI. It might get boring, but please pay a little attention to it because it will come, the themes will come in the video afterwards. So that's the token economy that I'm employing here. The spirit of MI is basically the music of MI. Without the spirit, the MI becomes just the lyrics. There is no music. So it becomes very bland. So what's the music for every MI session? The music is PACE. PACE is an acronym for partnership, where you collaborate with the patient. Acceptance, where you respect the autonomy of the patient and accept what he wants to do in his life currently. Compassion is when you put your client's best interest first rather than pushing your or the family's agenda. And evocation, the best ideas about the patient should come from the client, not from the therapist. So this is the spirit of MI that should always be there in every MI session. Then the core skills of MI, these are the core skills of every counseling session to be non-specific. Dr. Sunita in the first session was speaking about it. There's an acronym for it as well. So it's called CORES. O stands for open-ended questions. A stands for affirmation. R stands for a reflective listening. And S stands for summarize. And I'll briefly give one example for each technique to help you revise your knowledge on this. So open questions are questions which help people talk a little more. So they are questions where you cannot answer them either with a yes or no question or with a brief reply or a single answer response. Okay, I'll give an example. So if I ask Dr. Ravan here, sir, are you feeling depressed? So he will say either yes or no, or maybe. So these are single answer responses. It's not helping me explore his idea about his mood. But if I ask him, okay, Dr. Ravan, you are conducting such a fantastic seminar today. How are you feeling? He will start out, yes, I'm feeling really good. It's an excellent experience or whatever his feeling state is. So these are the powers of open-ended questions where the people cannot answer with a yes or no or a single answer response. Okay, they are door openers as they call it. Affirmation is the second technique that we use. Affirmation is recognizing the goods in the client. Okay, so a person, let's imagine a person who has come to you, he has had multiple unprotected sexual encounters, he has contracted HIV, he has IV drug use, he doesn't have money, he sleeps on the road, but finally he has mustered the courage to come to you for help. So rather than pointing out his problems, you can tell, what a difficult life you have had. I cannot imagine someone going through this much and still finding the courage to come to a hospital. Okay, that's affirmation. Or a person whom you had seen a week back, he has gone back and is drinking every day without listening to your advice, but then comes back after a week as you had advised. So appreciating that despite engaging in a behavior, despite engaging in a difficult situation, he has come back to your clinic, So you appreciating him on that is affirmation. So that is the technique that we normally use in MI. The third one is reflective listening. Reflective listening is you listen, you observe, then you mix it with your own experience and give it back to the client. Okay, so you basically make a hypothesis about the whole scenario and give it back to the client. I'll give an example. So the doctor says that you feel that since I have never taken any drugs, I'm not the one who should be giving advices to you. So that's the prelude to that is the patient says ki doctor aapko kya pata ki daru ka addiction kitna difficult hota hai. So that's your response. So it basically intimates to the client or to the patient that you are listening to him. You are trying to understand his frame of reference. Okay. So that is one technique. There are many types of reflections. I'm not going to go into that detail. Finally, summarizing. So when you are reflecting, reflections are statements. When you are ending a session or trying to discuss a different topic, you can basically collect all the reflection statements and give it as a summary. It's a summation of reflections, if you might call it. So basically ensures that the communication between the client and the therapist is very clear. Okay, so I have come to the area of which I'm supposed to discuss about. It's the principles of MI. And there is another acronym for that as well. I'm sorry for the acronyms, but you have to remember this. So the acronym for the principles MI is DARES, D-A-R-E-S. It's a very famous acronym. But D stands for developing discrepancy. A stands for avoiding arguments with the patient. R stands for rolling with resistance. E stands for expressing empathy, and A stands for supporting the self-efficacy of the person to make a change. What's developing discrepancy? So it's basically evoking the awareness of the client regarding the goals and the values that he has, and how does his current behavior of drinking, let's say, fit into that. Okay, so one good example is there. Help me figure this out. You have told me that keeping custody of your daughter and being a good parent are most important things to you right now. How does your alcohol use fit with that? So basically his priorities and his substance use behavior is being mixed, and he's asking to evoke the awareness about the discrepancy that is there. Then avoid arguments. One good analogy to this that normally people use in MI is that in motivational interviewing, you dance with the clients. It's not a wrestling that is happening. You do not want to pin the person down by your sweet talk or your gainful knowledge. You want to dance with him. If he's showing a difficult move, you try to modulate your movement so that the movement, the ultimate movement or the duet or the duel is smooth. Okay. So you have to work with the client. So do not engage in arguments. Roll with resistance. This is a difficult thing, but probably most important thing in MI. These days, you will get a lot of clients, young clients to be precise, who come up with you, who have cannabis use, and they'll tell you a lot of things about the good effects of cannabis. The doctor, medical cannabis is now approved everywhere. It improves your cognition, it improves your creativity. A lot of articles they'll cite, a lot of lectures they'll cite. If you go into the defensive mode and say कि तेरे को बहुत पता है, मैंने इतने केस देखे हैं cannabis induced psychosis के, मेरे को बकवास सुनने का, that basically it's not rolling with resistance. The person will not turn his back again to you. So the purpose of bringing a change in behavior is defeated. That is something that you do not want to do. So you have to roll with resistance. There are a few techniques that you can utilize to roll with resistance. One is reflection, as obvious. One is shifting focus to a different discussion. Okay. One is reframing the whole idea, and siding with negative. Siding with negative is when, for example, let's say Dr. Jigyasa is being my therapist now, and I tell him कि दारू तो मैं आराम से हजम कर सकता हूँ, मेरे को दारू पीने से कोई दिक्कत नहीं. So Dr. Jigyasa will give me a reflection statement. So you are trying to tell me, Dr. Udit, that alcohol has no harmful effects on you. So that's basically siding with negative. That helps me think, is it something that I'm saying or doing? Huh? So that's how we roll with resistance. Finally, express empathy. Empathy, as classically understood, is standing in the patient's own shoe. But in MI, I try to imagine it a little differently. I think If you understand the patient's frame of reference about the change, then you are being empathetic. And you do that by reflecting properly, by utilizing reflective listening. Finally, self-efficacy. This is probably the most important thing to bring a change. It's the ability of the client and belief in his ability to bring a change. So you have to support self-efficacy all through the sessions of the mind. Okay. So this is a cheat sheet, if you may call it. There are a few techniques that we normally utilize to evoke change talk so that people consider or start considering for change. One is obviously open-ended questions. One is provoking extremes. So this is a good example of provoking extremes that is written. Suppose you do not change. What is the worst thing that might happen? Suppose you keep drinking like this. How do you see yourself and your family after 2 years? Suppose you continue injecting in the same fashion as you are doing heroin. What do you think will happen to your family after 5 years? So something like that, provoking extremes. Something similar is looking forward. How do you see yourself and your family and your relationship with the wife maybe after a year or so, something like that. So how do you look forward towards your future? There are two rulers that is there. One is a confidence ruler and one is a readiness ruler. It's a simple one. So I'll give you an example question. So on a change of 1 to 10, 1 being not interested at all and 10 being very, very interested. How are you enjoying the session? Okay, so, or how confident you are that you're enjoying the session. So I'll answer that, let's say you respond 6. So I'll ask you, why 6, why not 5? Or why not 8? So it basically progresses the conversation forward. Finally, the very famous, the pro-con table or the decisional matrix as they call it. The benefits of quitting, the benefits of not quitting, the benefits of continuing, the benefits of not continuing. So that you put it in a tabular form and the patient reflects on it, and basically that might help them consider change. Okay, I understand it might have, my message might have got jumbled up in the whole list of abbreviations. So I'll put forth my message, what I wanted to convey in this session, and I'll probably go to the video right now. The first thing I wanted to tell is ambivalence is a natural part of any change that humans consider, including substance use. The purpose of motivation and interviewing is to accept and enhance that ambivalence and then guide the client in resolution of the ambivalence by eliciting change talk. Open-ended questions and reflective listening, they're probably the most important skills that you're going to utilize in MI. Evocation of change in the client and the idea of change, it should come from the client and you should guide it. You should not be putting forth the idea inside the client's mind. And do not try to win the battle in day one. Okay. Set specific goals which are realistic, meaningful to the client, and accessible, and which are timed. So with that, I end my session. There are a few suggested readings for you who are interested to know more about motivation interviewing. One is the book of motivation interviewing, helping people change, which was written by the MI guys themselves, Miller and Rolnick. There is another interesting book, Motivation Interviewing, a guide for medical trainees, that is also available in Amazon and other forums which you can buy. And the BMJ Learning has a module for MI. It's free of cost. It's open to all. And the teacher over there is Dr. Rolnick, so you can enroll and access that. It's a 2-hour online module that you can finish in a single day. Thank you so much. Before I go to the questions around, I'll probably show you the same scene again, but with different dialects. And after that, I'll take up the comments on that video and other questions.
Hello everyone, I'm Dr. Bhubaneswar and I'm working as a consultant psychiatrist with the Master's Academy. So today, me and my colleague, Dr. Daniel,
demonstrating a role play, and I'm playing part of the doctor. So the case scenario which we will be playing is that a 40-year-old man who is employed in a private company has come to his family physician with his son to get him evaluated for repeated ear infection. The doctor found out that the father is a smoker from a questionnaire he filled. The following is a conversation but the doctor is trying to advise the father to quit smoking. Hi, Mr. D. So I wrote a prescription of antibiotics for your son.
Okay.
I did want to talk to you though. I'm a little bit concerned looking at his chart that how many ear infections he has had recently. And I've also noticed that you have checked the box that someone is smoking at home. I was wondering if you can tell me a little more about it.
Oh, well, doctor, it's just me, my wife, and him. I do smoke. I really try hard not to smoke around him, but I have been smoking for last 10 years. And you know how private company jobs is so stressful these days. And COVID had made many things very difficult for us. And I think I started smoking after I joined this job only.
Okay, well, Mr. D, seems like you have a lot of things going on and smoking is kind of a way for you to relax and de-stress.
Yeah, yes, of course, doctor. And some people have to bear, and I have a cigarette.
Okay, sure. It sounds like you're trying not to smoke around him. Why did you make that decision? Why are you doing that?
Yes, doctor, I know it's not good for him. And I have read those things about infections and asthma and stuff and all. But other kids have ear infections and their parents don't smoke.
Okay, so on one hand, you were worried about how your smoking might be affecting him, your son. And on the other hand, you're not very sure whether it is really the smoking that causing all these problems. Do I understand you right?
Yeah, right, doctor. Yeah, he does not have asthma. He does not have a lot of other problems like that his other friends have. And I have thought about quitting before in the past, but I just don't see how it's possible right now.
May I know when did you quit and what made you to decide to quit?
The year my son was born, I was there with him for a lot of time as his mother was not keeping well. I just don't think I could leave myself if something had happened to him.
Okay, right now though, it feels almost too difficult to manage without smoking or even to try to quit at the current moment for you.
Yeah, doctor, exactly.
May I ask, how are you successful when you quit that time? What did you do exactly?
I don't know, doctor, exactly, but I think about it now. I don't even know how I did it. I just did it. I just could not imagine him being sick because of me. Also, my wife made me swear on my boy so that I was just enough to say, okay, you know what, I'm not going to risk that.
Okay, so the risk was so scary then that you were able to stop yourself from smoking, right?
Yeah, exactly, doctor.
But they don't feel as scary to you now.
No, doctor. We are two separate people, and like I said, I'm pretty good about that. I also don't let other people smoke around him, So, I think.
Okay, so it seems that you are doing the best that you can do right now.
Yeah, doctor, right. You're right.
But I cannot help but notice it sounds to me that a part of you really wants to quit.
Yeah, I know that I need to do. And every new year I stay this year, I am going to quit smoking. But then something happens at work and quitting just does not happen.
So is it safe to assume that it's on your do-to list, but it's just not making to the top?
Yeah, exactly right, doctor.
Okay, if you did decide to quit on a scale of 0 to 10, where 0 being not confident at all and 10 being maximum confidence, where do you think you would stand?
Probably around 5, kind of in this unsure area. I know I have done it before, so I know I can do it. But at the same time, it just seems really hard. And it's not the same situation, right?
Sure. Answer me this. What made you say 5 rather than a 2 or a 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. Actually, I don't want him to use any substances. And so I know I need to, especially before he gets old enough to understand what his father is doing. But I just don't know if I can do it.
Okay, so it sounds like you have a lot of reasons why you would like to quit. You have been successful quitting in the past. And right now you're just feeling a little bit hesitant about your ability to do it.
Yeah, right. Exactly, doctor.
Okay, now tell me this. Where do you think we should go from here?
I don't know. I would like some help, and I just don't know what kind of help I need even.
Sure. Well, if you would be interested, there is something that we can definitely talk to you about. There is a lot of new options that can actually help people be way more successful in their attempts to quitting than before. There are different medicines that you can try.
But doctor, I don't like taking medicines.
Okay, that's okay. the other options also, there is a lot of support groups, there are helplines that you can talk to. There are people, it's good to have people with you when you go through this phase. Sometimes just having that support can be a big part of quitting, especially for people like you, where smoking is such a stress reliever.
That sounds nice, and but I'm not sure even if I have time for all that, doctor.
Sure. I understand. It feels like something that would take up a lot of time and maybe not fit for to be put into your life right now. I wondered if you could talk about some other options that might fit into your life ahead.
Oh, that would be really nice, doctor, if we can talk about.
Okay. Let's take things a little slow. If you are willing, we could set up another appointment where we can come in and we can talk more about this.
Oh, I would like that, and it would be great help, doctor.
Great. So I'll see you next week.
Sure. Thank you, doctor.
Thank you, Mr. D.
Okay. Besides my second Oscar and another film, what do you think happened in that video? So tell me what I'll ask a very straightforward question. Did I utilize any of the things that I spoke in the slide on the presentation? If yes, then what? If no, then why not? Yes, Dr. Avan, yes, that's true. I asked a lot of open-ended questions. Did I summarize by any chance or give any reflection statement? I did. If you remember, I was telling him that you have shown that you were capable of quitting in the past, but right now you don't think that's very important. So that is something that I was reflecting. That is something known as a double-sided reflection. Okay, so I was reflecting one side of the ambivalence, which is good, and I was also reflecting another side of the ambivalence, which is bad. That's something known as a double-sided reflection. So that's something that I did. What else did I do? Did I respect the autonomy of the client? I did. No, I did. Actually, it might be kind of frustrating. I'm giving so many options and he keeps denying. नहीं दवाई नहीं खाना है, नहीं time नहीं है मेरे पास आके group में बैठने का, नहीं online therapy नहीं कर सकता. So what we decided on is that just come again. Okay, we'll take things slow. Just come and let's talk about it. Let's find out a middle ground. So that's essentially it's a way to talk to people. Okay, this client might have been a little smoother because he's my friend and he's acting, but real life patients might be in much more denial, much more pre-contemplation. So a good idea would be just to ask open questions, keep summarizing, reflecting, keep listening to them, and keep enhancing that ambivalence when you see it. Okay, and keep rolling with the resistance. If you do that, I'm definitely sure that, if not now, maybe after certain sessions, people will start talking about change. People will have that change talk inside. So with that, I end my presentation. If there are any questions, any clarifications, someone has asked me about my mail ID in the chat. So it's Udit Panda, UDITPANDA @gmail.com. I'll put it in the chat box for everyone's convenience.
Is there any questions from the audience?
Yeah, people have pointed out about the acceptance that I showed, the exploration of ambivalence, the rolling with resistance, using reflection. Very good. So I hope my message is conveyed. Sir, yes.
Real life situation in addition to it. Mostly we come across patients either being forced to be brought by the guidance or they, to whatever extent I've seen, either they're forced to come or else they will come and show you on the very first day a very strong eagerness to change. Very strong eagerness to change. As a sensitive patient, at times it's difficult to understand
whether there is a real readiness for changing the patient, or the patient is using some kind of defense mechanism. So, theoretically, even if the patient is in a pre-contemplation stage or in the contemplation stage, the process is similar. But how to exactly dissect between these two constructs, whether it is in the real pre-contemplation stage or whether there is an antibody which is already started, or else is using some kind of a difference to just go cross over that.
Got a question. So it's basically that's the dilemma of socially desirable response. When people just to evade this doctor's assumed nasty comments that alcohol is bad, you are ruining your life, and no, you should quit, which everybody has been telling them since the day they have started drinking problematically. So that happens. I believe, keeping in mind 2-3 facts or 2-3 concepts will be helping in understanding and navigating through the situation. One is substance dependence is a chronic relapsing remitting illness. So lapses and relapses, they are the rule, not the exception. So lapses and relapses will happen even to the best of motivated clients. Second is motivation in itself is a dynamic construct. So it may so happen the person was in a pre-contemplation phase when they came to a clinic, and by the time they go out, they are actually in a preparation stage, or the reverse. They are in a action phase of motivation to quit, and you said something and they are pushed into pre-contemplation phase and just get out of your clinic and start drinking again. Now, it's true. It might be difficult to look through the denial, to look through the rationalization, to look through a veiled socially desirable response and find out the actual phase of motivation or actual stage of motivation. But then again, that's not something that that's not the target of MI. The target of MI is to help him explore his ambivalence. So it might be in the first session that they are not, they tell you that they are actually willing to quit and go out and start drinking again and do not come back. So that itself is an indication that they were not motivated to bring a change in their behavior of drinking. So maybe if you keep your clinic windows and clinic doors open for them, if they understand it doesn't matter whether I drink or not, if I come back here, there is a person who is sitting who has unconditional positive regard for me and who is going to listen to me, then maybe after 2 or 3 sessions, you might start having results. So I believe, sir, yes, that's a practical situation. I won't deny that. But rolling with that resistance is something that's best we can do. Yes. No, it's not comparative. That's no. It's mostly your current self versus your ideal self, in the sense the goals and the values and the aspirations of your ideal self versus how those goals, values, and aspirations are being affected by your current behavior. That is in question, or that is an examination.
Very wonderful presentation and nice question. Very well presented this topic, and how to go for MIT thoughts, and also to some extent how to go for this motivational interviewing. And already we are 10 minutes crossed this time limit, so we'll stop here and we'll go to next session. Thank you.
Thank you.
Thank you, Udit sir. Thank you, Sujit sir. I would now request Dr. Swati Mishra ma'am, MKCG Bharatpur, to felicitate Dr. Surjit Sahu, Dr. Sarmishta Priyadarshini ma'am, And on behalf of Dr. Dheeraj Kadula sir, Ravan sir will be taking his. Swati Mishra. Please. Thank you, ma'am. Dr. Dheeraj, yes. Dr. Dheeraj Katula, sir. Sir, I would like to have you make some end closing statements regarding the theme.
Yeah, first, I wanted to congratulate Dr. Udit for such an excellent presentation. Thing is that he could reflect the way we are on in the first video, mostly the ones actually who are caring and actually who are knowledgeable. But the process was the problem in that particular case, and his lecture dissected the video and showed the right way forward, and his later video actually demonstrated a beautiful way in which it should be done. I just remembered a story that happened a couple of years ago. I saw a person with a bilirubin of 10 continuing to drink alcohol, and I was concerned for him, so I stopped my OPD. 45 minutes I spent time with him, and he did ask one question: "ऐसे करेंगे तो क्या होगा?" Then I said, "खतरा हो सकता है, जान का भी खतरा हो सकता है." I was trying to be as soft as possible. That's what I thought. A couple of weeks later, I came to know that he came to the hospital with a pistol to kill me, to show किसका जान कौन ज्यादा जिएगा दिखाता हूं उसको. The point is that we should know when to back off. Despite your concerns, you should know that you have reached a limit. Dr. Udit told about the story in which he's explaining about cannabis-induced psychosis to the client. But he says, no, ऐसे कुछ नहीं है. There's no entity called psychosis, cannabis-induced psychosis, it won't come. But it's not the time for us to demonstrate the evidence for psychosis risk in cannabis use. It is time for us to back off and continue the conversation and later prove those things. So that wisdom is something that we will accrue over time. All these principles, it's not that it's like a checkbox that you can actually learn and just do it in one day. It's over as days go by, as you keep dissecting your own, how you have dealt with clients, you will become better and better as a therapist who does the motivational interviewing. I also like the fact that he did not go into evidence base and produce statistics and how many session 1 may ye karo, session 2 may, because we never know. What is important is for us to learn the principles and use. We never know his patient is going to come back the second time or third time, but at the same time we should know that we cannot overload him in the time that you have possible. So be wise and tune these principles to your setting and follow these principles correctly. And wishing you all the best. Wish Kims, who's conducting this wonderful sessions about counseling in everyday practice. Wishing you all the best. Thank you.
Thank you so much, sir. Dr. Ravan will be collecting your felicitation on your behalf. Okay, next we have Acceptance and Commitment Therapy for Adolescents by Dr. Jagyasa Ipsita Patnaik, MD, DNP, PDF, Child Psychiatry, St. John's Medical College, Bangalore. Assistant Professor Kims. As online expert, we have Professor Dr. Sarda Swai, Director, MHI and Editor, Odisha Journal of Psychiatry. Subject expert, Dr. Samradkar, Consultant Psychiatrist, The Brain Institution, Cuttack. And as moderator, we have Dr. Prashant Mahapatra, Senior Consultant and Chairman Award Committee, IPS, Odisha State Branch. I would like to invite Dr. Samradkar on stage and kindly brief us about the theme. Thank you.
Good afternoon all. Thank you, organization.